me that we had quite a number of very promising candidates for this award, and as a consequence, we voted more than the usual amount of people to receive the award this year, this month, which I think is very encouraging. So, first individual winner is Molly Wallace, and she was awarded. Molly is the service manager for haematology and oncology. She was nominated from a member of staff for displaying instrumental support to the Rigby and Aylesford units during the extreme times of pressures. The nominator said how Molly shows amazing leadership and adaptive ways of working, and that Molly's role would normally be known but not visible to the wider team. She's now a recognised member of staff to all the nursing and clinical team. You can tell I'm reading this verbatim, but the nominator finished by saying that the two units have had to merge and relocate to provide a safe service from one site due to our reducing numbers of chemo-trained nurses and significant cancer referral increases. The staff on the units have shown nothing but resilience and flexibility in this, and Molly has supported in any way she can to enhance the organisational and administrative elements of our service needs. She has taken on administrative duties of senior managers so that their time can be focused clinically. So well done, Molly. That's really excellent. Well done.
Thank you.
Okay, so congratulations. The second individual winner is Suzanne Bullymore. Suzanne Bullymore is a Rigby unit manager, and she was also chosen along with Molly as an individual winner. Her award is for selflessness and commitment. The nominator said that she always leads from the front and is first to lend a helping hand to any task without a second thought. Her support and direction to patients and visitors. Oh, that's proper English there. The nominator also commented that Suzanne has continued to put patients, their families and staff at the heart of everything she does, with a constant smile on her face every day. For the Queen's Jubilee, Sue wanted to make sure that the unit could celebrate in style and that the patients coming in for treatment and the staff working on bank holidays didn't miss out. She took her time to sew flags for the unit and make decorations. She bought snacks and drinks as a gift for the patients so that they had more of a variety on the tea rounds. If Sue was a stick of rock and you broke it into two, it would have the Rigby and Aylesford unit running through it. So again, congratulations, Sue, for your performance last month. Your work. Oh, Gertie, you've raised your hand.
Sorry, Simon, I was trying to clap.
Right. Oh, I see. Okay. Hear myself talking about it. And then finally, the team winner is the Children's Diabetes Nursing. The Spring Team GEM Award was awarded to the Children's Diabetes Nursing Team, which consists of Helen Allen and Mandy Aspinall. The team were nominated by a member of the public for showing total compassion, care and understanding to a family whose daughter had been directly impacted since her type 1 diabetes diagnosis. The nominator said how the team go the extra mile daily by recognising the needs of the children in their care. Helen and Mandy arranged for several children with type 1 diabetes to attend an escape room experience and meal out together. The children were made to feel so welcome. The nominator continued that their daughter didn't know anybody at the event and could be quite shy, but the team ensured she was included and gave her the confidence to make some new friends. In the nominator's daughter's own words, she could finally speak to people who could relate. Fantastic. Well done. Okay, so thank you all very much. Congratulations. And we'll now move on to the board meeting and the agenda. So apologies for absence, Russell Hardy, who's on his holidays, and Rosemary Hyde. Are there any declarations of interest? Okay. So are people happy that the minutes of the meeting held on the 6th of July are a fair and accurate reflection of the meeting that took place, or are there any comments and observations? Okay, very quiet. So items for approval: operational capacity plan and winter plan. Agenda item 6.1, Harkamal.
Hello. I will just quickly share my screen. And I promise I will try to be quick. I know that this is quite a big presentation, but it's going to be quite a big year. So, as you know, because I've been saying it ever since I've been in post, urgent and emergency care remains under significant pressure, and it has been one of the busiest summers that we've ever seen, with record number of attendances, and dealing with not only the heat, but another wave of COVID. At SWFT, I think it's just really important to couch this in. We've cleared our elective backlog. We don't have any patients waiting over 2 years. We've managed to get down to just a handful of patients waiting 78 weeks, and we've offered now 90 patients additional mutual aid. And TNO are almost back at the top of their leaderboard. I think they're second in terms of waiting times in the last month. And it's against that backdrop that I prepared this winter plan. So in terms of what we think is going to happen, it turns out that we are actually quite good at projecting what is going to happen. When we look at what we did last year, the numbers that we thought we would get, we were there or thereabouts. And that's what this slide sort of shows you. So the top graph is our ED projection against the actual attendances, and you'll see that over the past few months we've been there or thereabouts within the orange line. When you look at them where we think we're going to be in terms of admissions and where we project to be, we are within the range that we thought we were going to be. And the reason I wanted to kind of draw everyone's attention to that is because this is sort of the best we've got. I think every year we get told that it's going to be the worst winter ever, and it's against unprecedented demand and all the rest of it. But it's really important, I think, to try and prep for what we think is going to happen based on the data, and then just to sense check what the data is telling us. And this is where we look like we've been in terms of our bed occupancy. You'll see that we've actually been higher on occasions on our projected bed occupancy, certainly in August, and we've definitely felt the impact of that internally. But this tells us essentially that January and February are going to be really, really challenging for us. We know that, but it's a significant increase compared to what we've seen in the past in terms of a dependency on our beds. We've also got the impact of the Australian flu, so the impact of the prediction of the number of hospitalisations that we're going to have. We anticipate that to be slightly earlier in the year, so any time from October onwards. So that's something that we need to sort of factor into our thinking, not only because of the numbers point of view, but the practicalities of what do we do with these patients. Pre-COVID, we would have just isolated flu patients as we normally do. But when you've got COVID and flu, and you've got two different cohorts of patients, it's going to be really, really challenging to manage that group of patients within our side room cohort. And the priority sort of has to be to protect flu patients from getting COVID. So trying to manage that dynamic within the organisation, I think is going to be quite challenging. But it's certainly something that we've started to think about already, and we are putting together SOPs of how we would risk assess against that. We also want to protect our elective capacity at all costs, and also have a plan for staffing, because I think that is going to be our biggest, most significant challenge that we're going to face. When you've done all the maths, essentially it equates to a very catchy 73 bed challenge. So what are we going to do? The NHSE has set out some core objectives and some key actions for us that they want us to meet to prepare for operational resilience. So that's both for the acute and for the ICBs. And we started to measure our progress against these objectives. I won't go through each of them because they are in the pack, but actually none of them are a worry. They're all things that we're sort of working on already. There are some things in there that are key for us though. So really making sure that we're expanding our virtual ward offer, ensuring that our capacity outside of the acute, so what our urgent community response looks like, and with the virtual ward offer, they're going to be the things I think that can really save us. They're things within our control, and I think are really important that we focus on. The other thing I want to pull out of that, and I'll talk a bit more about it, is around the reducing hospital occupancy. We have seen a reduction in our length of stay, and I think it's really important that we carry on with that piece of work, but also further that in terms of our winter planning and our preparedness for winter. So in terms of what we are doing right now, we are looking at a bed reset, so trying to understand where our demands are in terms of the specialties, and where we need to try and make sure that our beds are profiled against. Obviously coming up with our winter planning schemes, and I'll talk you through some of them. We are almost finished with the 100-day discharge challenge, and that was to try and assess our baseline of where we are against a set of metrics around discharge, and then really use that as part of the plan to get ready for winter. Expanding our virtual wards, as I've already said, and then internally we are doing a changing for the season, a reset in line with some of the principles from ESIST, but they're also looking quite eagerly to see what we're doing to see if they can expand that anywhere else. So in terms of our winter planning schemes, it's a similar slide to last year in terms of the principles of making sure that we're not just focusing on what happens when patients get to us. It's just as important to make sure that we understand what the pre-hospital and admission avoidance bit is. Once they're in ED, we absolutely know that there is work to do in terms of our streaming and making sure that we're getting our processes right in ED and doing things that have worked really well in the past. So additional porters, for example, it's quite simple, but it really does make a difference on the day. Ensuring our in-hospital processes are what they need to be, and that we've got really good focus on like the back door and our discharge essentially, and then making sure that discharge and the out of hospital support is there, because what we don't want to see is just loads of readmissions because we aren't doing things safely or efficiently, and making sure that we are capturing all of that. Within that, some of the elements such as Docabo, I think are going to be really key for us. We're already doing really, really well on that in the north, and it's about learning from that and seeing what we can do to replicate that everywhere else, and what can we do to work in that way with our partners in care homes. That could certainly offer a significant opportunity for us. The domiciliary care pilot for rapid response, pending the outcome of the discharge front runner, a similar scheme is being worked through by Warwickshire County Council, and that is going to be key for us. We know that we really struggle in terms of the volume of patients that we have in our beds that need domiciliary care. So engaging in that and pushing that is going to be vital. So in terms of the winter planning, this year we've done it slightly differently, because what I don't want to do is present a plan that sort of says it's all fixed and it'll be fine, and then I just spend January and February telling you how awful it is and that we're really, really busy. So we've been winter planning since April, and we've been meeting monthly, and that's a multidisciplinary approach, including clinical nursing and finance and ops, to try and pull together some schemes. And I've asked this year that the things that have worked in the past, we just do those. So, putting an extra paediatric registrar on, we know that that works. We know it works to move a T&O doctor down to the front door. We know that the additional porters work. So let's just do some of those. But where we have additional schemes, to really make sure that we're doing PDSAs and make sure that we're doing the study and the ACT bit. So far, we've got 26 big schemes identified, and 21 of those have got PIDs that are being managed through my operational project management unit. Within that, the biggest ones are the medical day case unit, which is working phenomenally well and is actually supporting flow. We've reopened Stratford minor injuries unit. As yet, that hasn't had an impact on our numbers at Warwick, but we will continue to do that analysis. And then there are a number of other schemes there, but essentially that leaves us with a 33-bed gap, which is the equivalent of a ward. So it's really important that we continue to work and try and identify more schemes. This is all in the pack, so I won't go through it, but this is basically the start of the bed reset that we've done. And if I tell you the hardest thing to do was to try and determine how many beds we have in this organisation, I think you'd be really surprised. But the key is to really take out any assessment and observation capacity. It's really important that if we are saying that something is assessment and observation, we keep that going, because that is the key to our flow. And so we're all sort of, talking about the same thing. Within that, though, we've done a bit of analysis on what patients actually turn up into our organisation with and what they need. And you'll see that actually geriatric medicine is our biggest pressure point. So what we're doing at the moment is working through how we can best profile our beds to try and match some of that demand. And we know that the frailty work that our teams are leading works really, really well. So how can we maximise that and try and push more patients through that pathway to avoid admission, but also once they're in, make sure they're getting the best care they can and not spending too much, that cohort of patients, and not spending too much time here or more time than is necessary. There's also an interesting thing, and it happens everywhere, in terms of what patients are admitted with, and it's usually general medicine, and what they end up being discharged with. So it's really important that at source we get that information correct, and that's a piece of work that we're doing. But essentially, people tend to get admitted under general medicine, and then they tend to move over to geriatric medicine. So it's just about making sure that we're identifying the right patients at the beginning. I talked a bit about the 100-day discharge challenge and in terms of our baseline. So within the pack, I've included a bit of narrative on where we are against each of these. But it has been really interesting to do this analysis. So this was just day one, and you can see that actually, if you take the period from the start of at the end of June, actually we weren't really making that much difference. It was there or thereabouts in terms of our discharges by day, 80-20 split between weekday and weekend. In the first 25 days, our performance actually decreased, and although our weekend discharges went up, it wasn't really statistically significant. But actually, from day 25 to day 50, when we've had the focus piece of work on this programme, we have started to see improvements in discharges by day, and that's backed up by our reduction in length of stay. The issue still remains, though, weekend discharges, and that's a piece of work that we are embarking on at the moment in terms of what more can we do around criteria-led discharge. And there are opportunities for improving on that in our operational battle rhythm that I'll talk through a little bit later. And to support this work, we actually did a speed event. So we basically went through almost every single patient in the organisation to try and understand what they were doing here and what we could do to try and safely discharge them. And that learning has fed into some of the winter plans that we've got. I'm also meeting with the COOs in the rest of the group to compare and contrast our progress against this before our November board session, so that we can see if there's anything that we can learn from each other and which of us are doing certain bits better. I think that'll be really, really important. The next bit that I wanted to just touch on, I've mentioned it quite a bit, is around virtual wards. So we were successful in our bid for funding as part of the ICS, so there is investment that's coming with that. And frailty and acute respiratory are the areas that are mandated to have virtual wards. And that the rapid evaluation is a progress of frailty, and I will try and remember to incorporate that in one of my board reports moving forward, so that everyone's got a bit of an insight into what that looked like. But we're managing that through left shift. We've had really, really good engagement in that from our clinical teams, and we have identified SROs for that piece of work, which I think is really important. We're also doing a changing for the seasons programme. So that starts at the end of September. And essentially what we've tried to do is encourage everybody to come up with a PDSA, at least 2 per specialty, to really think about what can we trial for 2 weeks. There's no stupid idea, and we'll just try it. So we've committed to that, and so far we've had 40 PDSAs come forward. That is significantly more than we expected, and this initiative has grown quite significantly. So we've got our colleagues in catering coming up with ideas, which I think is brilliant. So that'll be a really good, rapid way of just testing some of these things and then studying it and then just putting it in practice if we feel like it works. And based on this morning's tool, I've put in that I think there's an opportunity to link in the HEAT tool around that piece of work. So I'll make sure that we do that. So what are we going to do next? So the operational management and the grip, I think, are going to be really, really key. Charles, Sarah and I have already agreed around having that triumvirate approach to flow management and ensuring that there's a medic, a senior nurse and a ops person every single day identified to support with this through the on-call arrangements. The exec on-calls, I've got 8 willing colleagues who have agreed to do every weekend on call in between now and in between the 3rd and the 11th, 3rd of January and the 11th of April, to make sure that we've got those people who are really around the ops all the time, so are able to make sort of safer decisions. And we've planned for hospital protocols kind of proactively, and every Monday during that period will be a Monday reset, and we'll have a really strong battle with them so everybody knows what to expect and what the responsibility is. during this, it's really important that we don't lose track of the productivity and the financial control. The productivity element of this, I think, is key. So we're working to think about how we can make sure that our governance arrangements are really robust, especially around agency control. We'll hear a little bit more about that later, but not panicking around thinking it's going to be really busy, and proactively putting some of those measures in so that we can support and then spot which areas look like they're under pressure. We're almost at the end of the audit of the internal professional standards, and I think once we've got the results of that, that will help us with our consistency of practices. The people bit of this is key though, and you know, we're proactively recruiting into gaps, looking at our junior doctor posts, looking at where we've got locums, but against the backdrop of the recruitment you know, issues that we have, and the vacancies that we're carrying, and the pressure on our staff, with the risk of industrial action, this I'd say is probably our key bit, and the bit that is perhaps keeping me up at night a little bit. And then finally, it's just important to continue to work on closing that 33 bed gap. We know what it is, and we're all open and honest about that, and it's key that we keep our eye on that. And some of the next steps that we're doing are an out-hospital clinical summit. We've just done an in-hospital one, which was brilliant, and we had loads of engagement through that. So, you know, drawing on our colleagues and asking for their support with this. So I've got to say, when I pulled all of this together, I did panic, because it just feels so big, doesn't it? It's always overwhelming, and I don't think it's always helpful to tell people it's going to be the worst thing ever. So I reflected a little bit on the last year. And last winter, I told you it was going to be the worst winter ever, and we got through that. It was our first winter without restrictions. We've had serious pressures from the system, including from our ambulance colleagues. So we saw the introduction of the immediate ambulance handover protocol, and that put an immense amount of pressure on our staff. We managed to navigate through that, and we continue to work with our colleagues on mental health and CHC and dom care. COVID, monkeypox, RSV, the Commonwealth Games, we actually declared, which we never do, a full hospital protocol on the 14th of July. So when we think about a busy winter, actually we've had a really, really busy summer, and we hit 103.9% bed occupancy on that day, which is why we triggered that full hospital protocol. Obviously we've had our heat waves, which I'm really proud of to say that we responded really, really well to that, and had a minimal amount of cancellations when you compare us to other organisations. And we already know what our staffing challenges are. We're already working through that. So in summary, I think we can do it, but it's probably going to be quite difficult.
Okay, Harkamel, thank you very much. So we'll take questions and observations for Harkamel in a minute. Just after that, we'll go back and do matters arising and actions, which we glossed over a little bit at the beginning. So Phil, you've had your hand up for a little while. Perhaps you'd like to go first, and then we'll go to Glenn.
Thanks, Harkamel. It's really good, really comprehensive, and very thorough. So my two questions were, have you given enough time to what we're not doing? So have you made all the lower risk, lower value calls to get them out of the way to create additional capacity and or sort of buffer? And then on page 38, the vacancies, how many are there? What's the pipeline look like? And is the pipeline going to deliver what you need?
So Gertie, get ready to answer the second one, because I'll come to you. With regard to the first one, yeah, I think that's really important, and certainly that's what we're discussing at our clinical summits, but probably not enough, if I'm honest. So what I'll do is take that away and make sure that through the divisions we are really thinking about that low-hanging fruit, and that's from all perspectives, I think, from the clinical and also the ops and the sort of the day-to-day stuff. So I think Sarah, Charles and I will take that away and factor that in, because there's definitely opportunity around that, and that I need to play into this, because that will definitely have an impact on the bed reduction. Thank you.
Simon, do you want me to follow up and answer the second question, or?
Please, yes, please do. No, Gertie, go ahead.
Phil, is the pipeline enough? My view would be no, not for want of trying. I think there's an awful lot of work going on around recruitment, particularly around speeding up recruitment, improving the recruitment. I mean, great suggestions this week around from Harkamel around how we showcase all of our wider careers. If you look at the IPR later, there's 76 new recruits in the last month, of which 55 were clinical. So there is a healthy pipeline. There's a lot we can do to make that leaner, slicker, speed that up coming through. We've also got the ambition we talked about in board a couple of months ago of increasing our recruitment by 10%. And whilst I think that's a challenge, I think it is achievable, and making the recruitment much quicker, along with the plan to recruit 50 international nurses and increase our number of apprentices. So collectively, there is a huge amount of work going on, and I think we're moving into a space of really trying to upstream that. But there's always more we can do, and always more we can do to improve that. So I will continue to do that. I mean, I'm meeting fortnightly on recruitment with my teams at the moment, and with Sarah and the nursing team. So a lot of work going on.
Gertie, thank you very much. So we've got 3 more questions which we'll take, and then we'll move on. So Glenn.
So firstly, Harkin, that was a great presentation, and it really gives a really good overview of the things we need to do over this winter to hopefully make it as good a winter as it can be, including some things that we still need to come up with. But what's good about the organisation, and we had a visit from Amanda Pritchard, the Chief Executive of the NHS, a couple of weeks ago, is that we've got lots of people with lots of ideas who are really keen to try them out, and we're really keen to support them and implement them. So I'm sure further ideas will come, and that attitude is going to serve us well over this period. I was going to make some points during my Chief Exec report, but Simon, it probably is easier just to do them now, because they're
go ahead, Glenn. Yeah,
and I'll then be brief when I come back to the Chief Exec's report.
Okay.
I think there's 6 things that I think we need to focus on over this period. I mean, firstly, doing the things that we know work, but doing them consistently throughout the week, throughout the weekend. And as Harkin shown, there's some opportunities for improvement around discharge at weekends. I think, though, the second one is we need to change our approach to risk. And we need to ensure that we're not just looking at the risks of the individual patient in front of the clinician. We're considering the risks of people waiting in an ambulance at the front door versus the risk of discharging people potentially a little bit earlier than we would otherwise, and balancing that risk across the whole system. We also need to focus on care homes. So what was fascinating in the data was, 24% of our admissions coming from falls. Some of those will have happened in care settings as well as at home. And so I think being there as the best friend of all of our care homes in our system, using the technology that we've got through Dockerbo to actually keep those individuals in the place they call home throughout winter, I think is so important. We need to get on a COVID footing with this, and that isn't about going into level 4 major incident. This is about us dealing with some of the things that Phil touched on there, actually, which is just making sure that we make it as easy as possible for people to get on and do things, and to not be bureaucratic about processes, but to, particularly our frontline staff, to free them up to make decisions and support them in doing that. Number 5 is about supporting our workforce and making sure that we're considering their well-being throughout this period, but also dealing with some of that recruitment and retention challenge that we just touched on. We're already looking at being more flexible about retirement options for staff and things like that, but we absolutely need to get that one. And then finally, the one for me is being really close to our colleagues in social care. They've got some significant staffing challenges. We've got some ideas about how we can help with that, but we need to stick together as a local place, as a local system, not finger point at whether some parts of the system are doing what they need to do, whatever. We're all going to be under pressure. If we stick together, we're going to make this as good a winter as it can be, and I'm convinced that we will do that well. We had a film crew here from the BBC National this week looking at our discharge processes, and they'll be doing a piece possibly tomorrow, but over the next few days, about how well it's being managed and the pressures that we're under. But we've got some great people, and what we spend our time doing as a board, therefore, over the next few months, I think will signal what's important. So we'll keep coming back to this and how we're getting on with it. That's all I want to say. Thank you.
Okay, thanks. Glenn, can I ask you, how will we see as a board then how we're doing against those 6 challenges you set ourselves?
So we'll capture them as part of the updating through the performance report and some of the things I talk about. There's also likely to be some system level monitoring of capacity that's available throughout this winter. That's hopefully being put in place soon. So whether it's about virtual ward capacity, whether it's about bed capacity, just tracking that and making sure that we're using it to the full.
Okay, thank you very much. Okay, Charles.
Glenn has very eruditely covered pretty much what I was going to say. But there's one thing I would just add in response to Phil's question about stopping doing things. I think the threat of industrial action as an extra pressure gives a very sharp focus on a kind of what if plan, which I think we will have to develop some contingencies, and that same list of sort of escalation of things to stop doing will be very useful to have in our pocket anyway. So I think that we need to get on and do that.
Thank you, Charles. And finally, Richard.
Harkamel, in terms of the analysis you've done, I can suspect that there's going to be a change in mix from pre-COVID to post-COVID. Some of it's the delay, but anecdotally I hear from other people that there's a huge increase in adolescent females with eating disorders, but also a lot of males in the sort of 25-35 year gap who've never thought about being ill are suddenly committing suicide, or as soon as they find any symptom, they're coming to A&E. Have you seen any of that in the data?
Yeah, and certainly on the impact of mental health, and I think, and we've had conversations at board, haven't we, and done a board workshop on some of our more challenging paediatric patients, and we don't expect that to go away, so that persists as a challenge. And I think the key is to remain close to our colleagues, and we've got a really strong framework now of actually escalating and tracking some of these patients through, but I fully expect that to remain a pressure point for us.
Okay, thank you, Harkamel. Okay, should we move on then? Thank you for your presentation, Harkamel. Can we go back and just pick up matters arising in the actions update report? There's not too much on it. So the Associated Director of Operations for Support Services to provide figures on ambulance handover, that's complete. As is the CFO to provide the chairman with data for system plans for the break-even position, also complete. And the COO to pass the balls thanks to security colleagues, which Harkamel has done and is now complete. So actions in progress relate to 22.133 integrated performance dashboard, the chief nursing officer to provide a reflection on the reason for the reduction of births at the midwifery led unit, and that's Sarah's deferred until next month's board meeting. Great. And then working on the remaining outstanding item, which refers to security incidents at Stratford Hospital, is also work in progress. Any idea, Harkamel, when we can report back?
Yeah, I've done that.
Oh, now you can. Yeah.
Yeah, no, it was only Rosemary wanted to see the information, so I've emailed it to her.
Oh, have you? Okay, understood. That's lovely. Okay, so now we can leap forward again and talk about winter flu. And that is you, Sarah.
Thanks very much. So the team have been working really hard for some time on the flu plans, which is actually enabling me to say today that I think we've got some really strong plans in place to deliver a successful flu and COVID vaccination programme this coming autumn. So just a few key points. We've planned a really high energy campaign for the first 6 weeks, focusing on a clear message around protecting yourself and your patients well before winter sets in. It's using a combined approach. So in COVID, where we had a booked approach because of some of the restrictions, and previous flu campaigns where we've had roaming vaccinators. So using the opportunity of both both methodologies because they both have their merits. We've got over 90 peer vaccinators that are already signed up to deliver peer vaccinations across the acute trusts and the community. We have received some updated guidance, national guidance actually yesterday, but I don't see that being a problem to our plans at all. Be easy to deliver. And so I think really the only thing holding us back is actually the delivery of the vaccine. As you get closer to the date, it becomes a bit more reliable, but we are hoping to commence vaccinating week commencing the 19th of September.
Okay, Sarah, thank you very much. Are there any questions or observations for Sarah? Richard, is that a legacy hand, Richard, or you're asking a question? I can't, Richard's on. So let's go to it's a legacy. Sue Whelan Tracy.
Yeah, hi Sarah. From my read, there's lots of learnings gone into this, and the significant one that jumps out to me as being different this year is around the speed of which you want to get all staff vaccinated, because we're usually looking at quite a long tail across into the new year. So what analysis have you done to help work out, who tends to go last and how to get them further up the queue?
Well, Sue, that's a really good point. I'm not sure we have done that analysis, so that's a very helpful suggestion that we can take on board. I think there is something about the learning from previous flu campaigns that a really clear message of expectation and making it really, really easy in the initial weeks. I think we are hoping to motivate some staff that have previously taken a little bit longer to reach. And I'm so pleased that we've got 90 peer vaccinators signed up, because that will allow us to go out to areas. We are going to increase the frequency of the of our data dashboard. So operational leaders will be able to see every week how many of their colleagues have been vaccinated. And I think that will really help us in those first 6 weeks to adapt and respond to how it's going in different areas. But I will suggest that we look back at the areas that have been, I'm sure they probably have those detailed conversations. It's just I've only recently joined, but I will make sure that we have done all the learning on previous groups that have been harder to reach.
Sarah, thank you very much. Thank you, Sue. So we'll press on again, and item 6.3, Sarah, is the updated trust constitution.
Thanks, Simon. So we convened a constitution working group to review the trust constitution to ensure it reflects the current practices and processes that we've got in place. The proposed amendments are shown as track changes, which have been reviewed by the trust solicitors to ensure that we're legally compliant. And there will be further changes once the model constitution has been updated to reflect the Health and Care Act 22. So it's submitted to the board for approval prior to going to Council of Governors tomorrow for ratification. Thank you.
Sarah. Okay, thank you, Sarah. Does anybody have any questions or observations for Sarah? No. So if you're unhappy to approve the new constitution, can you please raise your hand? Otherwise, I'll assume it's passed. Okay, Sarah, that's approved.
Thank you.
Thank you. So moving on again, we now move on to Glenn, item 7.1, and the Chief Exec's report. Thank you, Glenn.
Thank you, Simon. So I'm just going to pull out a few headlines from the report. The major item within it actually talks about the National Winter Plan, which we've obviously covered the local version of. I start with in our usual kind of understated fashion, we've moved to a name change to South Warwickshire University NHS Foundation Trust, which is we're still going to keep the abbreviation of SWFT, particularly after Central TV used that SWFT by name, SWFT by nature piece the other week, which I rather liked. But quietly in the background, we moved to the name change. I was very keen to ensure that we did this at a minimum cost. So thanks to Chelsea, my executive assistant, and Mary, particularly in comms, who worked hard on making this transition happen at points where we needed to replace things or change things. But we are at South Warwickshire University NHS Foundation Trust. So actually, one of the unexpected benefits of that has been the arrival of Pramjit as a new non-exec who's brought additional skill sets to our board and a focus on research. Then I'll talk about Commonwealth Games. Again, quietly in the background, emergency planning teams made sure that that was an absolute success. It really was great to see the Midlands, particularly great to see Warwick there with the cycle race, which went right past my door. Provision of mutual aid. We in that central TV piece, the focus on the orthopaedic team and the work that they've been doing to help patients from other parts of the Midlands has gone down so well. The patient feedback has been incredibly positive, and we've had a further visit from the BBC, which I mentioned earlier. So the winter plan, I won't go into lots of detail on this, but just to signal a couple of things. Firstly, this is the earliest I've ever seen a winter plan produced nationally, and I've been around a few years, so it must be the earliest ever for the NHS. It's good to have it early, but in itself, it hasn't quite got enough solutions in there. So these 7,000 beds or bed equivalents that it sets out will be helpful, but we'll also need to do a number of other things, and Harkamel has already gone through some of the things we'll be doing locally on that. But the bed equivalence bit of it, so it's all very well saying we need more beds. There's not lots of staff available to open more beds. So being inventive about improvements to patient pathways and taking that kind of marginal gains approach to improving flow will be really important for us. We're already doing some really good work on virtual wards, but I'd like to see more of a focus on that. And I mentioned earlier, particularly that making sure that patients in care homes are kind of virtual ward enabled so that we can keep them in the place that they call home. I then refer to the August meeting of the 3 boards in parallel. We will be doing that on a quarterly basis, and future meetings will be in public. I report back here on just a couple of things we looked at, particularly the productivity analysis was quite stark in that we looked at a number of the business cases that we'd agreed pre-COVID, and obviously COVID has meant that we've not necessarily delivered on some of those because of particularly staffing challenges. But it's also an important reminder for us as we look at business cases that when we increase our staffing base, it's not always easy to do that with recruiting permanent staff. So I think once we start to look at the risk of that being agency delivered, we might start to make some different choices in the future. Then I talk about Victoria Ward, the stroke changes that are happening. Whilst Victoria used to be our acute stroke ward, it's a really important part of our bed stock, which I think Harkamel has helped to emphasise there. And the increasing cohort of frailty patients and care of the elderly patients mean that we will be reinventing Victoria Ward as part of our general acute beds. The information governance team then, I won't go into it, but it's a service that is transferred to Innovate, but is a service that is combined between George Eliot and SWFT, which is one of those things that we're able to demonstrate. Just a little bit of extra scale of the two organisations working together makes it an even better quality service. And then we go through, which we've already done, the GEM Award winners. As I say, there were a huge number of applicants this time. There were a large number that went through our recognition group, which is the group that filter them and put them forward to myself and Gertie, who have the really tricky job of deciding what the winners should be. And we ended up doing more than one individual winner this time because they're worthy. But it's always the nicest part of my job to look through those and just see the great things that people are doing. So well done again to those individuals. So I'm happy to take any questions on this.
Okay, thank you, Glenn. So any questions or observations for Glenn? Okay, none. So that's very good. Obviously told us everything we needed to know. So let's move on and look at the integrated performance dashboard report. So Anne, would you like to start us off, please?
Yes, thank you very much, Chair. Just by way of introduction to the Integrated Performance Dashboard, just really to flag the point that's highlighted in the Chief Nursing Officer's report, our positive reporting culture and learning from incidents. Harkman has already outlined the challenging July that we have had and the heat, and where we enacted the full hospital protocol on the 14th of July. But also against that backdrop, the referral to treatment performance that we achieved 72% in July 2022. And our third successive month of improvement for the diagnostic weights. What we haven't touched on, or hasn't been touched on in my narrative, is the cancer performance. And in the Chief Operating Officer's report, it sort of flags the long-standing issues that we've had on cancer performance. And that is a concern, given a key elective recovery target is our 62-day weights. And that really flags the scale of the challenge. The Chief People Officer's report details the work underway around recruitment and retention initiatives really to improve our vacancy position. And in the Chief Finance Officer's report, it details the mitigations that are in place and the real focus that remains around our workforce and our productivity improvement plans, and that being the main focus for our finance and performance executive meetings that we are having with the divisions. And although there is some risk there for the organisation, which I'm sure will be covered in Kim's update. So really I'd hand over to colleagues to go through the detail of our performance dashboard. Thank you, Chair.
Thank you, Anne. So before we move on to Sarah, has anybody got any questions for Anne? Okay, thank you. Sarah, over to you.
Thank you, Chairman. So if I may, I'm going to comment on medication incidents and falls. So medication incidents, the report highlights that there was a slight increase in July, but it also demonstrates that the rates are very stable over a period of time. And I think it's really good news for the organisation that the number of harm incidents still remains very low and low when benchmarked nationally. And it's particularly pleasing to see the work that's been done on insulin incidents, which has in July demonstrated a reduction in those incidents. So early days, but very pleasing to see that. In terms of falls, the overall rate per 1,000 bed days is still very good when benchmarked. And this is a difficult agenda because we're balancing the deconditioning agenda, which is so important, with preventing falls. But I would like to acknowledge that there were 2 patients who had fractured hips during July. The care that was examined in the RCA was good for those patients, but actually it has generated some ideas for how we can further work to develop our care of patients to prevent falls, which again I think is really good to see. So happy to take any questions. They were the comments I was going to make.
Super. Thank you, Sarah. Any questions or observations for Sarah? Okay, thank you. So Harkamel, talk about the your performance.
Yeah, so Anne's picked up most of the bits that I wanted to talk to. In terms of the area of focus, I've included a bit of narrative on cancer. So clearly it is our most pressing challenge in terms of trying to achieve this target, and it has been for some time. But I just wanted to provide some information or some background again on what we're actually doing. So against the backdrop of really significant increase in referrals, we are also doing the most treatments that we've ever done. So Q1 for this year has been the highest quarter the highest number of treatments delivered. I've just had the data through, so I'll include that in my next report, for any treatments that we've ever delivered in any quarter one, or indeed across any quarters. So I think that was kind of my take-home message from this. We are really aware of some of the pathway challenges that we have. But across the Midlands, we are the second highest in terms of our increase in referrals, and that is not abating. And when you look at our referrals for August, we actually saw 329 more referrals this August when compared with last. And for our first time ever, we had more referrals in August than we did in July. We are also seeing, unsurprisingly, a significant amount of patient choice, and that's certainly feeding into the figures that you see in the report. And I think against the backdrop of the increasing referrals, that hasn't been matched with the increased expansion of our teams. And even if we wanted to, we would not be able to recruit fast enough to keep up with this demand. We are still delivering more and more treatments. So I've included a little bit around the practical things that we are doing. So continuing with our pathway referrals, and continuing to invest where we need to, but recruitment is a real challenge. And as I've said, the rises are so significant, it will just be so hard to keep up with that. Primary care is our key partner in this, so we continue to work with them to try and manage some of that demand. The only thing I would say is that actually our conversion rate has increased as well. So it is not a phenomenon around loads of inappropriate referrals. A number of these patients are actually converting to have cancer and then needing that treatment, and they're presenting later, so they are more complicated, and it's taking longer to pull these patients through the pathway. Diagnostics is certainly a key issue for us and was the key driver in our 62-day performance. But we've done a lot of work to try and increase our diagnostic capacity significantly across radiology and endoscopy to meet the rising demand. That said, even within that increased capacity, we are still way above the demand that we've ever seen before, and we are one of the most responsive diagnostic providers in the country. So it's just to sort of capture some of that in that. The cancer care navigators have been really, really good. So they have been introduced as our first point of contact for our patients. And they are the people that patients ring to just understand where they are in the pathway, and to try and understand what it is that they need to do to try and move themselves forward. They're also the people who are trying to ring the patients who, when they say they can't come in because they've got holidays booked, try to have that conversation around, do you know what this actually means? Do you know what you've been referred to? Is there anything we can do to try and support you to come in? So it works really on both ends. We've also changed the governance arrangements around it now. So weekly, I now go through every single patient that has breached and every single patient who has got 11 days to breach, literally line by line, so that we can understand and see what else we can do to move that forward. And I've asked our colleagues in the pathology network to provide some more data so that we can actually track down to an individual patient level, because that does persist mainly within gynae. But we're working through how we can have a better escalation with them. And just broadly, the risk is that if referrals continue at this rate, we did not expect to see this in August, then there's perhaps a different way that we need to try and work some of this through. The final point is that the tumour sites that we are struggling with are the tumour sites that everybody is struggling with. So it's not that we're a national outlier in the performance when you kind of compare it to others, but absolutely we could and we want to do a lot better than we're doing now.
Harkamal, thank you very much. Claire.
Yeah, the cancer 62-day performance is a worry. As Harkamal says, we have seen particularly high levels of demand. Harkamal refers to choice, and just to elaborate on that's patients from outside of our normal catchment area being referred into us for cancer treatment. We just need to understand whether that's a change that's going to continue for some of the edges of the patch. But I'm in two minds about this one, because if you go back a couple of years, primary care was being criticised nationally for not referring enough cancer activity to us. And indeed, a lot of cancer cases in the UK come from emergency admissions to A&E. And so if this is a shift to a more appropriate pathway, particularly when you think about how we've put in advice and guidance arrangements where GPs can phone our consultants to seek advice, and if our consultant's saying, yeah, don't send them into A&E, we'll give them a 2-week wait appointment or whatever it might be, that would be a good thing. But what we need to do is to ensure that we've built our capacity to respond to those changes in demand. So I think the thing that probably Hogmel would be good to look at is whether those patterns are different by GP practice, and whether there's any areas that we need to perhaps just spend a little bit more time talking to GPs about.
Okay, Glenn, thank you very much. Charles.
Yeah, there is engagement with the GPs via the Strategic Innovation Board, and we have the Niggles group. But I just wanted to support what Glenn had to say. Is if you step back from all of this, the challenge was that cancer survival is better in Europe, and if you look into it, a lot of European countries have much higher levels of diagnostic capacity, and they have a lot more incidental findings of early tumours. And one of the problems is that actually, by the time you've got significant symptoms from cancer, it may well be at a more advanced stage. So, as night follows day, if you want us to diagnose cancer early, it's going to be when actually clinically it's not very clear, the symptoms are relatively minimal, and that means doing more diagnostics and widening the net to get the result you want. So, I think this is to be expected. And I think too, it is an area where, a primary surgical treatment that cures cancer is better for everybody. It's not only obviously much better for the patient and the patient's family, it does prevent a lot of unpleasant and often expensive downstream treatment. So, it's one that we really should be supporting.
Indeed. Charles, thank you very much. And finally, Sue.
Yeah, just to pick up on that, I do think it's really important that we take the patients with us and communicate as best we can. It's great that we've got the navigators, but we can't keep throwing people at this. And it still astounds me that nowhere in the NHS is there a patient support management system for cancer. So anyway, that's just my regular thought on that. But I wondered about the out of area ED attendances and at 18%, and whether the length of stay of those patients, those of whom are admitted, is substantially longer than local, please.
For those patients who then need any sort of support from a dom care or social care point of view, it is longer. That is an area that we really struggle with. Repatriating those patients is a constant headache for us, and certainly that's something that we constantly feed back to our colleagues in the ambulance service around when we're doing intelligent conveyancing. All these patients are choosing to come here. There has to be that understanding of what the knock-on effect is of that. So certainly my conversations with WMAS are around, if we're going to keep sending patients here from out of area, and they're those more complex, elderly patients, they're then going to be much more tricky to get out, because we know that, we know that length of stay is higher, and then that is a knock-on effect into admissions from ED. So it is a cycle, but it is a problem.
Okay, thank you, Hogmel. Glenn, and then we'll move on.
Yeah, I was just going to come in on that point, and it's a really good one, and we need. This is where integrated care systems can maybe play a stronger part in helping us to get those pathways out of the hospital. Right now there are 84 patients in the back of ambulances across the West Midlands waiting to go into an A&E, and there's another 25, I think, that are en route to those A&Es, and in Worcester there's 10, in UHW there's 15. So those ambulances waiting, and we rarely have that situation. So more of those ambulances over this winter, as it gets tougher, are going to be either diverted or intelligent conveyance towards us. So this is potentially a problem that will get worse. So we need the rapid discharge of those patients to be something that we fix over this winter.
Okay, thank you, Glenn. I think we do need to move on, but I can see that Sue's decided we are going to move on from her question. But Charles, you have a question, and then we will move on.
Yeah, mine was a residual hand that I've just removed.
Oh, okay. Right, smashing. Okay, so Gertie, let's move on and talk about workforce. Gertie, can
Thank you.
in your commentary, Russell has a couple of things he asked me to raise specifically. One was just to understand where we are on retire and return in our thinking on workforce. If you could just pick that up briefly as you go through the rest of your report, that would be excellent.
Yes, I will. At the moment, there's a significant focus on recruitment, and obviously we've had feedback about how bureaucratic and complex retirement term processes are at the moment, and there's a flexible working group that we've established looking at how do we streamline that. There's absolutely no doubt we can make this easier. The focus, particularly around the flexible working group and retention work, is about looking after the well-being of our colleagues, maximising our flexibility, as Glenn talked about earlier today, and supporting our colleagues, because what we do know is that if we look after our colleagues, if we help them develop, if they have a good experience, then they will stay with us and will give better patient care. And obviously the onward development of our culture sits central to that, because our culture is all about our staff experience. So really, really important work, Simon, and definitely picking that up. There's lots of improvements we can make. I think that's pretty much covered everything I was going to pull out, because Anne has picked up some areas, and we've discussed the new starters, etc. earlier in the commentary with Phil, but happy to take any comments or questions.
Okay, Gertie, thank you very much. Any comments or questions for Gertie? No, thank you, Gertie, very much. So, Kim, can we talk about the numbers, please?
Yeah, thank you, Chair. So the report for the month shows that we're delivering a break-even position against a surplus plan for the period of £1 million. We're still forecasting at the moment to achieve the 3 million surplus that was required for in line with the annual plan submission. The movement in month reflects really the recognition of associate income, mutual aid, and some release of some other non-recurrent benefits. We've got a session in the confidential board later to talk more about the reset work and some of the risks associated with the forecast position. But again, highlight some of those in the main body of the report. Non-delivery of our cost improvement programme is a challenge. And also our ability to deliver the activity in relation to the elective recovery plans, which affects the potential income figures particularly for the second half of the year, and the associated income with that. The other issues are continuing concern really around the level of agency expenditure. You will see that we've kind of reached a peak in July, which is of significant concern. Got a number of mitigations in place around managing temporary workforce, and those actions have gone through our management board, and again share those again in the financial reset paper. As I said, we'll discuss a bit more around later on around all of the measures in place to mitigate the risks potentially to the plan. But happy to take questions.
Kim, thank you very much. Glenn.
Yeah, we'll come back to some of how we manage through this year later. But just for my benefit, could you just confirm what the assumptions are in these numbers around energy costs? Because obviously the things may happen nationally to provide more cover for our current forecast.
Yeah, of course, Dora. So we were one of the fortunate organisations who negotiated their energy contract prior to the price increases. So in that sense, we don't have the same level of risk according to other organisations. So it's not going to be an issue for us for this year.
Kim, thank you very much. No other questions for Kim? Okay, thank you very much. So, Charles, learning from deaths. 153 of the pack.
Yes, really, the main indicators remain within control limits, as they have for some time, but we are seeing a little bit of an upswing in HSMR, which we've seen in other members of the group. And this is an indicator that's calculated a little bit differently from the SHIMI, which is our main and the nationally benchmarked indicator, in that it involves an offset for patients that have had palliative care codes. That means the palliative care team has been involved, and that does vary from organisation to organisation. So initial dive into this using our benchmarking partner suggests that our palliative care coding is lower than peers, and that is a likely explanation for this trend. If that is correct, it won't feed through into the SHIMI, because the SHIMI doesn't take into that to account because of the variability. So it's something to watch, and we're going to do further work to try and get to the bottom of it. I believe that some of the same issue has actually been the case in Wye Valley as well. But the headline figures comfortably within control limits. We're not an outlier, and I think it's also, you know, reassuring, rather like some of the other patient safety indicators. This is despite a very substantial, you know, increase in pressure on the organisation.
Indeed. Okay, Charles, thank you very much. Are there any observations or questions for Charles before we move on? Okay, so moving on to agenda item 7.3 is the monthly safe staffing report. Sarah.
Thank you. So if I may, I'd just like to start by paying tribute to our staff. It's been quite operationally challenging at times during the last quarter, but despite that, this report is able to outline that we maintain safe staffing, and I think that's largely due to commitment and flexibility of teams across the organisation. I think the other key point that I'd like to make is that despite the national context of staffing being very difficult, we have been able to strengthen our position in a number of ways during the last quarter. Really pleasing to see things like the review of health rosters, reducing the unavailability of staff, and that's at a time when sickness has been challenging. So I think that's good news. So really, this report lined us up for the next quarter when we really need to focus on reducing our reliance on high-cost agency. We need to complete our establishment reviews of our inpatient wards and of our ED, and complete our preparations for winter. One of the things I'd like to do over the next couple of months is looking at how I can provide you with some triangulation of staffing against our quality and patient experience metrics in this report. So I'll look at that with the teams in the coming months. And just the final thing to say, since this report came out, they've published a new establishment review tool for community. And I think that is great news for us. It's the first time we've had a national evidence-based tool that we're expected to use. So we've just received a license, and over the next quarter, teams within the community will be reviewing all of our community nursing establishments, and we'll include those in our annual establishment review that we present to the board.
Super. Sarah.
Very happy to take any questions.
Excellent. Any questions or observations then for Sarah? Sue.
Hi, Sarah. Before your time, I used to really rely on the unavailability or inavailability, I might have got the wrong word, chart, and over recent months it doesn't seem to be there. And you just mentioned unavailability, and being out with staff this month, I had some really high levels, over 50% in some areas. So I wondered, is it a concern currently, and can we have it back, or something that aligns with what's actually happening on the ground? Because sometimes these charts are a little theoretical for me.
Yeah, we can certainly bring that back, Sue. I didn't know you used to see that, and I'm used to looking at unavailability as well. In terms of your question, unavailability of staff has been the bane really of the pandemic for the last 2 years. So as you rightly point out, it's a key focus. It is one of the things that's within our gift to make sure that our rotas are compiled as efficiently and effectively as they can be. You know, it's sort of using our resources as wisely as we can. So yes, I'll see what we can put in for the next report. That's fine, but please do take assurance from that we've got a rota group which is supporting local leaders to make sure that they're using the tools that are available to them to, you know, just use some of the little tricks that make sure that we don't have everybody on leave one week and then, you know, nobody on leave the next week and things like that. And that does really help with provision of safe care and safe staffing levels.
Sarah, thank you very much. Okay, let's press on then, and we move to the Clinical Governance Committee report. David Spraggett.
Yeah, hi. Yeah, this is actually 2 reports because we've had 2 meetings
indeed
since the last board meeting. I think I'll just take them as read, given the time that we're doing, and answer any questions anybody's got.
Thank you, David. Are there any questions for David? Okay, thank you very much, David, for your chairing of the committee. So Sarah, it's you again, I'm afraid. So we're back on
Sorry.
the Patients Experience Quarterly Report.
So I was just going to raise a couple of points, if I may. The first seems right to comment on the PALS inquiries, which look like they have gone up a little bit. The analysis shows there's quite a lot of PALS inquiries around booking. We have put some commentary in the report, but I just wanted to offer assurance that that is a key focus for us in the next quarter. I think looking at whether there's something we can do proactively so that those patients don't need to contact our PALS teams with queries because they're already informed. And the other thing I just wanted to say is to acknowledge the Inspirational Volunteers annual report. It's such a fantastic read, and 450 volunteers, 17,000 plus hours in the context of a pandemic the last year just didn't feel right not to pay tribute. And one of the things I've really noticed as I've joined the organisation is the value and the way that volunteers contribute in so many different ways that is so valued by both our patients and our clinical staff.
Thank you, Sarah. It's absolutely right for us to thank them as an organisation for the amount of work and effort they put in for us. So well said. Okay, any questions and observations, Sarah? No. Okay, so moving on then, freedom to speak up, Sue Pike.
Hi, thank you, Chair. Sorry, couldn't get off mute then. So I'll take the report as read and happy to take any questions. There's just a couple of things I really wanted to highlight to you because it's about work that's coming up with you as a board. Okay. So in October, throughout Speak Up Month, you'll all be receiving some surveys, some MS forms to fill in, and that's so we can get your engagement with our board self-assessment that we'll be doing over October and November, and then coming to you as a workshop in December. So look out for those. We're hoping to be a bit more interactive than previously with setting our stall out, so it's not just Gertie and I that are going to do the work, you guys are going to do some as well. So hopefully that will go down well. And then just to highlight, throughout October we've got a whole host of Speak Up and Black History Month and Coming Out Day activities, as usual, some really good interactive sessions which hopefully will highlight the importance of speaking up, safety reporting and all that sort of thing. So and the other thing to notice from the report, because eagle-eyed viewers amongst you might notice there's a tiny gap in reporting, purely because we've switched to using Datex as a reporting system, and that started in April. So you might notice there's a few weeks where there's no data.
So thank you very much, and thank you for the great job you continue to do for us. Any questions for Sue? Sue Whelan-Tracy.
I don't have a question, but I had an observation. Hi, Sue. Just wanted to thank you for the comment, the clarity of your comment around the fact that all speak up incidents that involve patient safety are followed through in the way that's depicted in the report, and to congratulate you for getting it on today's text in terms of managing the information flow. I think that's really it's a real sign of continuous change, and you're always taking this field forward, so thanks for that. And yeah, and just to underscore my support that colleagues get involved with filling in the doing the self-assessment next month, because it would be really great to get a proper understanding of how each individual on the board feels about this topic. So thank you.
So thank you very much, and thank you, Sue Pike, other Sue. So let's move on, and we're back to Sarah again. So CQ, monopolising the meeting here. CQC Insights.
Thank you, Chairman. So the CQC Insights report is very stable. It shows a very stable position for the organisation. The slight deterioration in the responsive performance domain is related to access standards that we've discussed earlier on in the meeting. So I'm very happy to take any questions.
Okay, thank you very much. Any questions or observations for Sarah? Okay, Sarah, we'll just roll on in that case and talk about the maternity governance report. Just for the record, I think there was some concerns Anne raised about one or two inaccurate figures in the report. Is that right?
So I think Lynn is joining us to give the
Lorraine. Yeah, I'm here.
Thanks, Lynn. And can we just take the opportunity to introduce Lorraine Cardill? Lorraine joined us this week. A joint appointment between ourselves and George Elliott as our new director of midwifery. So Lorraine is joining Lynn for the first time this month. Over to you, Lynn.
Thank you. So I will take the report as read if that's okay, but I would appreciate the opportunity to highlight just a few points. I am hoping the report provides the board with enough information and a high degree of assurance that maternity services at SWFT are safe, and that we, as always, continuously strive to improve our care and our safety compliance. So firstly, just want to start with an apology regarding some of the data reported in the report. This is just in reference to Appendix 1, a new table showing a summary of details of the cases listed and which ones have been closed by our PMRT reviews were submitted yesterday, so it is available for you to see. This has just got further detail in it and clarity into the review process and the correct grading of care for each case, as it was just important for us to highlight that there's actually different gradings for different deaths in maternity. Also, just to say the table showing the data year to date below that in that same appendix is also incorrect. It does unfortunately include non-reportable deaths such as terminations of pregnancy. So for noting for the minutes, the number of stillbirths year to date is 1 and not 2, and the number of neonatal deaths year to date is 1, and it isn't a set of twins. So please do accept my apology for the wrong information provided.
Okay, thank you for clarifying that.
So the focus on the last quarter in maternity has been our continued hard work against the Ockenden report and our compliance. Our work on the maternity and neonatal safety improvement programme, where we are running several improvement projects. And as always, our focus is always on staff wellbeing and retention. So to start with, to share some really good news, we have been awarded the UNICEF Level 3 award for our infant feeding services. We have continually worked on this throughout the pandemic and have been commended by UNICEF for gaining such an award during such challenging times in maternity. And just to highlight that, I wanted to tell you the progress of a business case we've written to support the safe, efficient running of maternity theatres. This is so we can resource, hopefully, a dedicated theatre team, and we are hoping to take this to planning board in the next few weeks. In regards to saving babies' lives, we have seen a significant improvements in our compliance. Even though we're still not fully compliant, we have been commended by our work from NHS England, and we're fully compliant now with one standard, and we are on track to be fully compliant with 3 more standards by the end of the next quarter, just leaving 1 further standard that hopefully will be met at the beginning of next year. As you know, the Year 4 Maternity Incentive Scheme has set out new parameters, and therefore we need to be open and honest and let you know we won't be achieving all the 10 safety actions because, as I've said, we're not fully compliant with saving babies' lives just yet, but we are on track to meet 4 of them, and we continuously work really hard on all the other standards. As you can see included in the report from the Ockenden Action Plan, work continues against the 15 immediate and essential actions. Each of those 15 actions have multiple actions within them, and we often, when we review them each month in the MDT review meeting, we add actions to the action. So we are on track to complete 5 full actions by the end of the quarter, and now we have funding allocated by the LMNS that will really should support our progress, which is great news. We are expecting an unannounced CQC visit inspection anytime between now and March, and so we're busy preparing for this. But I think to note what's been really good is we've managed to reduce the number of red risks on our risk register from 9 to 2 with all the work that we've been doing. And as always, our work does still continue to improve continuity of carer, but just for our most vulnerable women at the moment. And any further rollout that is going to take place will rely on adequate staffing to make sure that's in place with full staff engagement programme and obviously an effective training programme. So I'm happy to take any questions, and I apologise again for the Appendix 1 misinformation.
Linda, thank you very much indeed. Glenn.
Yeah, thank you. Thanks for updating the numbers, and thanks for the way that you report to us, actually, which is it's really good to just have your perspective on what's going on in maternity services, and well done on UNICEF.
Thank you.
You know, that is really a significant development, as you say, over a really tricky period. Just wanted to confirm for everyone that the CQC will be doing unannounced inspections of every single maternity unit in the country during this period. So we're not being singled out, but actually that obviously relates to what's happened in a number of units, and obviously the Ockenden report. We look forward to seeing what further improvements we could make and how we benchmark against other services in the NHS.
Okay, Glenn, thank you very much indeed, and thank you once again, Linda. So I'm just conscious of time here. So are there any questions for Linda before we move on to Sophie's Green Plan update? Sue Whelan-Tracy.
Hi, just one quick one, Lynn. How we saw this plan, clinical governance, and weeks and months come to by, don't they, so fast? I just am aware that there's an awful lot in there for September that is on amber, and so I just wanted some reassurance about what amber means.
Yeah, so you're absolutely right, and actually, since if I shared today's action plan, it looks very different. But what we have noted, there was a lot for September that we've now either achieved or added another action to. But what we're going to do is we're going to retain where the first target was for that action. So if it was due in September, but we hadn't achieved it, we'll keep the September on, and then we'll add a new date, just so that we don't keep moving the parameters. So we set ourselves these goals, but that is for completion for the whole action rather than the multiple actions. So we might have achieved quite a lot, but the whole action still isn't fully achieved.
Okay, thank you for clarifying that. Okay, and thank you again. So let's move on, if we could, please. And Sophie, can you talk to us about item 7.9, the Green Plan?
Yes, thank you. The first thing to say is the report identifies a lot of work to date on this and a lot of progress made within the 11 areas. That being said, this is a 20-year journey and there is a lot more left to do. You'll see in the report as well that despite all our efforts, we are seeing an increase in our emissions. We've reported at board before around some of the decisions we've had to make around ventilation. If you look at where we're increasing water consumption and also the supply chain and inhalers. it's important to note that we are then trying to target those areas specifically because we know they're some of our key increases. So if I take supply chain for an example, there's a new post that's gone into Kim's team that specifically will look at this area of procurement. So we'd expect to see some progress against the objective that we've set as the trust as a bit of a spotlight on the plan. Coming back to ratings, there are a lot of ambers in there. And I guess that's because it is at the start. So we're seeing some of the targets this year green, but quite a lot of them amber because we've got quite a lot more work to do. The assurance I want to give to the board is that we have a sustainability group with all those leads attending. I sit on it and chair it as the exec lead, and Phil Gilbert joins us as the non-exec lead as well. So there's quite a lot of scrutiny on the green plan and how we're progressing it. And through these reports, the board will bring back any areas of concern. The big thing I wanted to talk to the board today around is the decarbonisation of our estate. We need to start making some of these big steps in the green plan to help us achieve that net zero by 2040. We had a really successful open day yesterday. We had over 10 companies come to our open day that want to work with us. And we'll now go through a process with those companies, which is set out in the appendix. Running parallel to that is obviously the hope that we'll submit a successful bid to Salix and we'll be able to fund that project. And we're, again, as some assurance to the board, you know, we're working with SEF in the background on this, and we will be ready to submit our bid. The risk I want to highlight to the board is that there's 178 million available for the NHS to bid against, but once 178 million pounds worth of bids have been submitted, it closes. So we don't know which day in September it opens. But as soon as it opens, if 3 trusts put £50 million bids in, then there's only about 5 bids that will be accepted. They shut the process. So it's being referred to as when you're trying to get tickets to a concert. It's that sort of approach, which is really disappointing because we are doing all the work to put it in, but we may still not be able to submit the bid. So just wanted the board to be aware of that risk to the Salix bid. And then finally, just to say, in terms of the bid that we put in, that will of course need a full business case that will come back through board. My hope is that business case is actually very easy considering what we talked about earlier around energy costs increasing. So we'll be able to demonstrate the benefit of moving towards net zero carbon. I'm happy to take any questions.
Okay, thank you, Sophie. Any questions or observations for Sophie? Excellent, thanks, Sophie. So we now move on to section 8 of the report, items for noting and information, and we're running about 15 minutes late at the moment, so if we can keep the pace going, that would be great. And summary of ratified policies, if you could talk us through that.
Paper is pretty self-explanatory. It just sets out the policies that were approved in July and August, and the changes made. So happy to take any questions on the content.
Okay, thank you. Any questions for Anne? Okay, thank you. So 8.2 is reports for noting. I think that's you, Sarah. Is it called to this? Yeah.
Thanks, Simon. I'm happy to take any questions from the IPC report.
Okay, thank you. Any questions for Sarah? Okay, thank you very much. Updated register of directors and register of directors' interest. Sarah, anything you'd like to add to the report in there?
Simon, I think you've just missed the the equality and diversity report. Mm-hmm. That's just after the infection control and report. It's a good one.
Oh, have I? Okay, let's go back. Gertie, can you do your quality in your report, please, if you could? I apologise.
Thank you. No, that's entirely fine. Thank you, Chair. The report is a very detailed report, so I don't intend to go into it. I would like to just take the opportunity to assure members of the public that we had a very detailed conversation about our equality, diversity, inclusion this morning, and it generated a lot of discussion and passion. I'm happy to take any questions about the report or the strategy moving forward.
Gertie, thank you very much. So are there any questions for Gertie or observations for Gertie about her report? Okay, so thank you, Gertie. Back with you, Sarah, on directors' interests.
Thanks, Simon. So both of the registers have been updated. The update is shown as bold, so it should be formally received and noted by the board. Thank you.
Okay, Sarah, thank you very much. And changes to voting rights for directors. So this is me, and the report is advising us that Rosemary Hyde, who is leaving us towards the end of her term shortly, will be stepping down as chair of the audit committee to be replaced by Richard Colley. And as a consequence, the report asks us to approve the transfer of voting rights from Rosemary to Richard. So,
sorry, Simon, it's just to receive a note rather than approve.
I beg your pardon, to receive a note. Thank you, Sarah, for correcting me. And that, I think, Sarah, goes to the Council of Governors tomorrow, doesn't it? For
that's right, yeah, and they'll approve it tomorrow. Yeah.
Lovely. Thank you very much. And then finally, that moves us on to board committee minutes. So, David, there are two sets of clinical government minutes there. Is there anything you would like to note on them or observe?
Not particularly, no. I think they're fairly self-explanatory.
Okay. Any questions for David regarding the clinical governance committees minutes? Okay, thank you very much. So we are now on to any other business. Is there any other business anybody would like to raise? Glenn.
I'll just mention that unfortunately Charles is leaving us to go on a period of planned sick leave. So best wishes to Charles on that. During that period, Dr. Pascal will be be acting up as Chief Medical Officer with a bit of backup from Chief Medical Officer at Wye Valley, David Mowbray, and Charles actually backed him up when he became Medical Director a little while ago. So there's a bit of reciprocation there, but we'll miss you, Charles, and hope you're back with us soon.
Indeed. Glenn, thank you very much. So I think, Sarah, that moves us on to questions from governors and members of the public. And there are two questions.
Do you want me to read the one submitted from Roger Lloyd?
Yes, please. That would be very helpful.
So Roger Lloyd, Public Governor for West Stratford and Borders, has asked, as SWFT is being asked to do more in all areas, including elective, does the Trust have the physical infrastructure to enable this to be delivered, or do we need more capital expenditure freedom to deliver the most appropriate clinical environment? Glenn, I think you're going to answer this question.
Yeah, I'm happy to do that. Thank you, Sarah. And thank you, Roger. So we did our estates review a few months ago now, and Sophie brought that back to the board, and that looked at some of the pressing issues that we have around our estate. So, notwithstanding changes in demand, we actually do need to invest in order to maintain, particularly our surgical day unit, but a number of other facilities, and we're in the process of pulling together some proposals on that, which we're also consulting with the public and with groups of staff on. So that continues, and that one of the key components of that is creating a protected elective hub within the site, which is still on the acute site but protected for undertaking elective activity, and that will. In doing the numbers for that, we've recognised some of the demand pattern changes, including the fact that we're certainly doing comparatively very well on elective waiting times, and we're now offering mutual aid to other nearby systems, including those not far from here in the kind of Solihull patch. We've also talked to the board about some of the urgent care demand changes. Earlier today, we talked about those too. And again, there's a little bit of a Solihull drift. There's also the impact of urgent care demand in Worcestershire and in parts of Coventry and Warwickshire also. So we're doing some work to look at the design of what we call the front door of the hospital. So looking at A&E and all of the ambulatory pathways that we have around the front door to just make sure we've right-sized those. And I think, though, Roger's question is more about access to capital, and that is a bit of a frustration. And thank you for asking me and getting me on my soapbox on that one again, which is, given the freedom that we had as a foundation trust a few years ago, we probably would have got on with some of these projects, but we now are constrained by a capital spending limit that is applied to the system. And so whatever capital we spend, we have to agree with system partners. I'm trying to see if they're willing to change the rules on that nationally linked to the success of the group, and maybe give the group a bit more freedom on that. And I'll gladly update the board if we make any progress on it. But at the moment, it will be a matter of us ensuring that we've got a strong case for the investment on the site. But linked to that, in the last week or so, I know Sophie and colleagues have been showing some of our ICS colleagues around, giving them the B tour of the site. I think is probably the best way to describe it, which is to show some of the areas we need to invest in, which I think is, from the feedback I've had, has resonated with for example, Phil Johns, the chief executive of the ICS, who realises that, you know, actually, despite the estate issues, we're the most productive site in the system, and we need to make sure that we continue to be so by investing in it.
Glenn, thank you very much for that. And there's a question from Mary Malloy that she tabled this at lunchtime. So Mary, would you like to ask your question?
Yes, thank you, Chair. So I did not submit this in advance. In the Safer Staffing report, I noticed there's a table relating to pharmacy staff. It shows a decrease, as I understand it, in pharmacy staffing levels and the establishment of pharmacy staff. For example, a reduction of 9 pharmacists. Is this correct? And if so, what's the reason? And how can it possibly be justified, given the importance of medicines management in all sorts of areas of our work? I don't know who's going to answer that one, but
I'll probably answer that one first, Mary. And I'm certainly, one thing I will do is just go away and double check that, because as far as I'm aware, other than one thing which I'll mention, we've not disinvested in the pharmacy department. One thing we did do, which I know you were close to, is when we implemented the electronic prescribing system. There was a slight tweak to staffing, but not of that magnitude. So I just need to check whether that's a recruitment issue as opposed to an establishment issue. But I wasn't aware of a proposed disinvestment in that. And I'm looking at my clinical leaders on this call, and they're nodding in agreement with us. So we'll just double check that and come back to you if that's okay.
thank you. I know there's a recruitment issue, but that's very different from reducing the actual head count that's allowed. Yeah, thank you.
Indeed. Thank you, Glenn, and we'll come back at you, Mary, with that one.
Thank you.
Thank you. So that is the conclusion of the public board meeting. So thank you, governors, for your continued support and your attendance today. And we'll reconvene in 5 minutes at 15:40, at 20 to 4, after we've had a quick stretch. So see you in 5 minutes.
Thank you, Chair. There'll now be a fight at the sink. I'll see you in 5 minutes.
There won't be a fight at my sink.